Thank you, everyone. Our next guest lecture will focus on tackling resistant organisms. Chairing this session are Dr. Nilanka Pereira and Dr. Vimalasiri Uluwattagi. Please welcome our chairpersons.
Good morning. I am Dr. Vimalasiri Uluwattagi. Together with my co-chair, Dr. Nilanka Pereira, I would like to welcome you to the next guest lecture, which is tackling resistant organisms. I have the pleasant task of introducing the resource person. Is Dr. V. Ramasubramanian. He's a specialist in infectious diseases, adolescent and adult vaccination, and travel medicine. He is currently the head of the Department of Infectious Diseases, HIV and Tropical Medicine at Apollo Hospitals. And he is the past president of Clinical Infectious Disease Society of India. Over to you, Dr. Ramasubramanian.
Thank you very much, chairpersons, and good morning. I'm back once again today. And I've been given the task of talking to you about tackling resistant infections. And if you're looking at tackling resistant infections, the most important thing to remember is that you need to think out of the box. And if you want an example of how you think out of the box, this gives you the answer. Are you an alcoholic? This is coming after the liver session. We can help for liquor home delivery. So your thought process has to be different if you're approaching it. I have a few disclosures, but no conflict of interest. But I have a disclaimer where my topic, which says tackling resistant infections, will cover a lot of bacteria. I am going to restrict myself to mainly gram-negative bacteria which are resistant. But the principles, the template which I will talk to you about can be applied to other organisms also. If you look at the deaths attributable to antimicrobial resistance, that is infections caused by drug-resistant bacteria, going from 1990 to 2021, this was published just a couple of months ago, you'll find that though the incidence of infections in the younger age group has come down, okay, the death due to infections occurring in people who are middle-aged or above is actually gone up. And if you compare the deaths attributable, say for example in 2021, you will see all pastel shades. You find Sri Lanka a nice sky blue. But as you move along and come to 2050, you will find that now Sri Lanka is becoming angry. It's becoming more orange, closer towards the dark red which you see in India. In other words, the incidence of deaths due to antimicrobial resistant organisms is going to significantly increase. So we need to know how to tackle these organisms. And if you look at the 10 deadliest pathogens caused for burden attributable to AMR in the global area in 2021, you'll find that in South Asia, I'm sorry, it's a very busy slide, but I will tell you the top 10 organisms include Acinetobacter carbapenem resistant, MRSA, Streptococcus pneumonia, which is resistant to carbapenems, MDR-TB. Almost 6 out of these or 7 out of these 10 organisms are gram-negatives, which include Pseudomonas, Klebsiella, E. coli, and Acinetobacter, which are resistant either to carbapenems or to fluoroquinolone. So we are facing a huge problem with these infections. And the approach to tackling resistance involves these points. First of all, we need to define and understand the mechanism of resistance. We need to look at the importance of investigations. Now, if you're going to tackle your resistant organisms better, the most important thing you need to do is ramp up your investigations, your ability to detect them early so that you can handle them. The choice of therapy, whether you need to use mono or combination therapy, issues related to pharmacokinetics and pharmacodynamics, the role of therapeutic drug monitoring, and the role of infection control. So my talk in the next 17 minutes or so is going to deal with this. Now, this is the diagram for a gram-negative bacteria. And if you look at the mechanisms of resistance, it could be because of the changes in receptor, typically more often seen with gram-positive infection. So if the receptor is mutated and modified, the antibiotics cannot go and attach to it. The next is the occurrence of efflux pumps, which pump the antibiotic outside after it reaches the bacteria. It could be due to the loss of porin channels where the antibiotic is unable to enter the bacterial cell, or it could be due to the production of certain enzymes, typically beta-lactamases, which can destroy the antibiotics. So these are the four main mechanisms of resistance. If you look at the Enterobacteriaceae, that is Klebsiella and E. coli, it is typically due to the production of enzymes. But if you look at the non-fermenters, Acinetobacter and Pseudomonas, apart from the production of enzymes, it can also be due to the lack of porin channels and because of the production of efflux pumps. And I'm sorry, I'm being a little more delving deeper into microbiology. If you look at the beta-lactamase enzymes which destroy the antibiotics, the Ambler classification has come up with four types. The class A, which is mainly the ESBL. When I say ESBL or extended spectrum beta-lactamase, these are enzymes which destroy all the third generation cephalosporins. So none of your ceftriaxone, ceftazidime or cefiperazone will work. Class B are the typical metallo-beta-lactamase, which knock off your carbapenems, quite often seen in India and Sri Lanka. Then you have class C, which is the AMP-C. The AMP-C enzymes knock off the beta-lactamase inhibitor. So if you have piperacillin plus tazobactam, this will not work against organisms which are producing a category C enzyme. And class D, which is the OXA group of enzymes which also knock off the carbapenems. So these are the main mechanisms of resistance. And if you need to know how to handle your bugs better, you need to know the distribution of bugs in your part of the world. And this one clearly says in Sri Lanka, the main mechanisms of resistance which knock off the carbapenems are those which produce OXA48 or New Delhi metallo-beta-lactamase. So these two are the main enzymes which are seen in your bugs. So we need to, as I said, ramp up investigations, how to detect these resistant bacteria early. Studies have shown that a delay in the initiation of appropriate therapy increases mortality. So we now are moving away, even though the gold standard is phenotypic resistance. The culture followed by drug susceptibility testing takes 48 hours, 72 hours, and sometimes even 96 hours. And it's been very clearly shown, typically with, for example, fungi, that, for example, candidemia, that every 6 to 12 hour delay in the initiation of appropriate antifungals increases the mortality and leads to poorer outcomes. So we are looking at, I won't go into the details, but looking at more and more different methods of diagnosis, which include, genome sequencing, which include spectroscopy, which include multiplexing to detect the mechanisms of resistance early, because these investigations give us a very quick result. If culture takes 48 to 72 hours, you can get a genotype testing and determine not only the bacterial, the type of bacteria, but also the genetic mechanisms of resistance in 2 to 3 hours. This is what we do. I'll tell you about a study which we did before the COVID times. This was a time when the CARBA-R test was approved. The CARBA-R, if you subject the blood culture, the bacteria to it, will tell you what is the genetic mechanism of resistance, if any, that is found in the bacteria. So we did about 160 samples. This was in 28. I think this was between 15 and 18. This was a time when colistin was the main, the Brahmastra, which was available at that time. Out of 160 samples, total of 164 gram negative bacteria were flagged in the blood. So the flagging took anywhere from 12 to 24 hours on an average. As soon as it was flagged, we subjected that growth to MALDI-TOF to identify the organism. So if it was identified as it could be either an Enterobacteriaceae or a non-lactose fermenter. If it was a non-lactose fermenter, these organisms, typically the Acinetobacter and the Pseudomonas, have other mechanisms of resistance than just the enzyme production. So we left it out. But if it was either an E. coli or a Klebsiella, we subjected that to the CARBA-R test, which gave us the distribution, whether it had CR genes like OXA48 or NDM. So within a matter of less than 24 hours, we could identify the mechanism of resistance and de-escalate or escalate antibiotics. And we found that almost 10% of patients had an escalation and 30% had a de-escalation within 24 hours of starting empiric therapy, which was very useful for our patients. So this is using the available tests, as I said, 7 years back, to have an impact on the patient's outcomes. This figure tells us in broad terms what the recommendations are. If you have a very multiply susceptible bacteria which was susceptible to several antibiotics, the drug of choice could be either an ampicillin sulbactam or a ceftriaxone. I think that's very easy. The next is if it was an ESBL producer, even though based on current recommendations, carbapenems are the drugs of choice, typically for bacteremic episodes or severe infections. If it is a milder infection, we can still use a beta-lactamase inhibitor, a piperacillin tazobactam or a cefiperazone sulbactam. If it is an AMC producer, very often ESBL and AMC occur together, quite often in our country. So if it's an AMC producer, normally beta-lactamase inhibitors will not work. So in that situation, you have to use either meropenem or cefepime, which is stable against the beta-lactamase, the AMC enzyme. But if ESBL is also found, cefepime will not work because it may be stable against AMC, but it will be destroyed by the extended spectrum beta-lactamases. We have a newer BL-BLI which is currently available in India called a combination of cefepime and N-metazobactam, which is very useful in this situation when they have just ESBL and AMC producers. The other three groups, the KPC, OXA48 and MBLs, are those enzymes which destroy carbapenems. So KPC, which is not found in India, very, very occasional, will respond to various combinations, ceftazidime avibactam, meropenem vaborbactam, imipenem relibactam. None of these are available. Only this, the first one, is available in India, and I presume in Sri Lanka also. If it's an OXA48, again, ceftazidime avibactam will work. Cefiderocol is not yet available. But if it is an MBL, which is usually typically a New Delhi metallo-beta-lactamase, the drugs of choice would be a combination of ceftazidime avibactam plus aztreonam given simultaneously, or fosfomycin or cefiderocol. So in a situation where this is the most common kind of enzyme which we see, this or a combination along with this, the drugs which act would be ceftazidime avibactam plus aztreonam and sometimes fosfomycin which are available. There are several newer agents. Again, I apologize for this. I will just highlight the important ones. Sulbactam and durlobactam, which is the now drug of choice for Acinetobacter, is not yet available. Cefepime taniborbactam is in phase 3 studies, but this is unfortunately not working very well. Cefepime N-metazobactam, which is, I told you, recently released in India, is a very good agent, does not work against carbapenem resistant organisms, but ESBL AMC, it works very well. Aztreonam avibactam, which is currently available in parts of Europe, which is, as I said, currently we are using ceftazidime avibactam, adding to that aztreonam and giving it as a combination therapy. But this new drug which has aztreonam and avibactam is likely to come to India in 2025. And what is showing a lot of promise is the cefepime zidibactam. Cefepime zidibactam is available currently in compassionate use program in India, and actually also phase 3 study which we are part of shows phenomenal efficacy against carbapenem resistant organisms which include Klebsiella, E. coli, that which are resistant to the synergy, that is ceftazidime avibactam plus aztreonam combination. If it shows resistance, cefepime zidibactam seems to be working. So this is the new kid in the block which is showing a lot of promise. This is a summary of those infections which are caused by difficult to treat gram-negative resistant bacteria: Pseudomonas, ceftolozone tazobactam, or ceftazidime avibactam. This is not available. This doesn't work very well. So we are still looking at cefepime zidibactam as an option. For Acinetobacter, sulbactam, durlobactam is the only option other than colistin. Steanotrophomus maltophila, we are looking at cefepime zidibactam. And for Burkholderia cepaceae, currently we are using ceftazidime avibactam, but cefepime zidibactam is also a very good option. So these are looking at the future of beta-lactam and beta-lactamase inhibitors. But the choice of the drug alone is not enough. We need to understand the pharmacokinetics. Now this shows a normal the distribution of drug. This is a volume of distribution in healthy adults. In patients with organ failure, the volume of distribution increases. In patients with severe sepsis, the clearance increases. The volume of distribution decreases. Now, how does this affect the administration of a drug? Let me give you an example. If there is significant inflammation due to infection or pancreatitis or burns or surgery which results in a systemic inflammatory response syndrome, this causes vasodilatation. This increases the cardiac output. This increases renal blood flow, increases the glomerular filtration rate. So when the GFR increases, more drug is cleared out of the system. And this is what we call as augmented renal clearance, ARC. So in the early parts of SIRS or sepsis, there is actually an increased cardiac output which gets rid of the drugs very, very fast, which means you have to give higher dose of drugs. Your normal GFR, which is 100 to 120, increases to 140 or even more. The drug is excreted very fast. You need to give a high dose, typically with a beta-lactam agent. Another thing to keep in mind is certain drugs act by the concentration-dependent fashion. Aminoglycosides, fluoroquinolones, they act the higher concentration they reach above the level of MIC, the better the action. Whereas if it is a beta-lactam agent, it acts by a time-dependent fashion where you need to give the drug, keep the drug above the MIC consistently for it to be effective. So which means it makes intuitive sense if you give beta-lactams more often, or you give it as an extended or a continuous infusion to maintain it above the level of MIC. That seems to work. But actually, does it work? Please remember that if you're treating severe sepsis, your loading dose is actually much higher than sometimes what we use. Ceftriaxone 2 grams twice a day. Ceftazidime 2 grams 8th hourly. Cefepime 2 grams 8th hourly. Imipenem 1 gram 6th hourly. Meropenem 2 grams 8th hourly. So the severe sepsis involves a higher dose of a beta-lactam because of augmented renal clearance. But as I told you, we are also looking at extended infusion to see whether it helps. Another small twist to the tale. See, if you are giving a drug which is normally reaches a level in the blood above the MIC, the drug should work. It is not as simple as that, because if it reaches a level somewhere in this area where actually it will work, but the problem is it also can lead to development of resistance. What is called as mutant formation happens at this level. Only if the level of the drug goes above this level, which reaches somewhere in this area, that will prevent the development of mutant, what is called mutant prevention concentration. For example, in India, we used to use piperacin tazobactam. The dose recommended is 4.5 grams 3 times a day, or ideally 4 times a day, which will keep the level of the drug somewhere in this area, which will work very well, but it is not toxic. But we realized, practicing clinicians realized that even if you give 4.5 grams twice a day, which was less expensive to use for patients, it actually helped. So why do we need to give 3 or 4 times a day when twice a day would help? This is what happened. So we reached a level above the MIC, but the drug concentration was in this zone. Thereby, more mutants were produced, and now less than 50 or 60% of the times, piperacin and tazobactam actually works. So we have lost the drug because we have used a lesser dose, which worked, but led to a lot of resistance developing. That's a problem. But coming back to the question of whether we need to give an extended infusion of beta-lactams, which act by a time-dependent fashion, this was the MERCY study, which was done in 2023, unfortunately concluded that by giving a continuous or an extended infusion, it doesn't impact on the mortality. There is no mortality benefit. Another study, which was the BLING study, which came out in June of this year, again looked at a 3-month mortality, a 90-day mortality and the occurrence of resistance, and concluded that there was no difference in mortality whether the drug was given as 3 doses a day, for example, meropenem, or if it was given as a continuous infusion, but said that there was some slightly better outcomes. The mortality did not change, but there was slightly better outcomes. And this is a study which came in July of this year, just 4 months ago, looking at the extended infusion of beta-lactams, and concluded that in this cohort of patients, the therapy was associated with a reduced mortality for patients with severe illness or those which had organisms which were slightly on the higher side of the MIC, that was developing resistance. So if you're using it in very sick patients or those organisms which have a higher MIC, though susceptible, the MIC was higher, in those patients, a continuous infusion actually helped. So the jury is still out. We need to see how much of difference it will make. Couple of more points. The role of therapeutic drug monitoring in giving antibiotics. TDM has been shown to be clinically beneficial for aminoglycosides, voriconazole, and ribavirin. For most common antibiotics and antifungals, a clear therapeutic range has been established and the TDM appears helpful. The panel members recommend routine TDM for aminoglycosides, beta-lactams, linezolid, teicoplanin, vancomycin, and voriconazole in critically ill patients. So if you have a sick patient who has high resistance, then doing therapeutic drug monitoring will help. Unfortunately, it is not freely available, but this is probably what is the next step towards personalized medicine. Lastly, monotherapy or combination therapy. Earlier, we used to use 2 drugs, 3 drugs to help tackle resistance, but now the recommendation is if one drug works, give that one drug. Very rare situations where you need to probably have a very sick patient, very high levels of resistance, combination therapy can be used. And lastly, infection control. Infection control is a very important part of tackling resistance. In my experience, I've realized that adjustment with the right people is always better than argument with the wrong people. So people who are involved with infection control will understand this. You try to oppose somebody, a big surgeon, a cardiothoracic or a neurosurgeon saying what he's doing is not right, you lose your job. So be sensible about, practical about approaching. The future is personalized medicine, nanotechnology, how you can prepare your molecules in a better fashion to decrease toxicity. For example, polymyxin is now likely to come in a situation where nephrotoxicity can be reduced. So with all this, we are going into an age of artificial intelligence. Unfortunately, we are losing our common sense. We had to amputate above the knee. This is how artificial intelligence is going to lead us. I hope not, but the empathy is lost. So what should all practicing clinicians remember? A syndromic approach. When you have a patient with a fever, define the syndrome. Is it a neurological syndrome? Is it a meningoencephalitis? Is it a pneumonia syndrome? Is it a intra-abdominal infection syndrome? Is it a skin and a soft tissue syndrome? Define the syndrome, because once you define it, you will know which organisms is likely the etiology. Then you apply the local epidemiology to see in your part of the world which is the susceptible antibiotic which will work against them. Always prefer beta-lactams. They are the drugs of choice in most situations. If you're dosing, get the dose right. For example, we never use tigecycline 100 stat and 50 BD. Tigecycline is available here in this country. Tigecycline. So we always use 200 milligrams stat and 100 milligrams twice a day. That's the actual correct dose which works, even though it is off license. When you use a bolus, the bolus should always be even in patients with renal failure. The first dose remains the same. And if you're using a beta-lactam, 24 to 48 hours, you continue a higher dose before you change for renal modification of the dose. Don't reduce it immediately after the first dose, especially in a sick patient. Therapeutic drug monitoring wherever possible. Look at the site of infection, because some antibiotics will not reach the site. Even though nitrofurantoin is a very good antibiotic for urinary tract infections, it goes straight through your kidney and comes out. So do not use it for prostatitis. Do not use it for pyelonephritis. And there are certain newer drugs which show promise but not yet clearly shown. My last slide, the take-home message is, we are all in a hurry. We are very eager to start the antibiotics because we feel that in a sick patient, you delay the start of antibiotics, the patient may not do well. But sometimes in our hurry to do things fast, we may not do the right thing. Your resume says that you're quick in mathematics. What is 17 into 19? That is 35. But that's not even close, but it was quick. Which is what we are doing. We are starting antibiotics quickly, but quite often we don't start the right antibiotics. So let us think a little bit, take a step back, go through the process, put the template in, and then choose the antibiotics. Thank you.
Thank you very much, Dr. Ramasubramanian, for that very interesting talk as well as quite timely topic. I think we can take probably 1 or 2 questions from the audience. Yes.
I have a question to Sir. Linezolid in cirrhotics with thrombocytopenia. How safe is it? Linezolid in cirrhotics with thrombocytopenia.
Now, linezolid in a person who has thrombocytopenia doesn't make it worse. It's not like, for example, rifampicin can cause thrombocytopenia, but it doesn't mean that if your platelet counts are a little low, rifampicin is contraindicated. Like that, linezolid can be used. But of course, we are now finding that for up to 7 to 10 days, the drug is well tolerated. Beyond that is when we start seeing the complications, whether it is neuropathy, acidosis, thrombocytopenia. So for a short course, it is acceptable. The newer drug, which is called tedizolid, which is again recently licensed in India, shows promise. It has less side effects than linezolid, which can be used longer.
Could I ask just one more question? So we also see a lot of resistant organisms, especially in ICUs, VAP. So these gram-negative coliforms, if it's not Acinetobacter, then do you do genotyping in all your cultures and then use your antibiotics, or do you have your microbiome and then?
It's a cost issue. So ideally, if it's a sick patient in the ICU, we do what is called the BCID panel. The bioMerio has come up with a BCID panel which tells us within 2 hours what is the bacteria and what mechanisms of resistance it has. It costs about 20,000 Indian rupees in my hospital. But in a situation where an ICU stay for a day can cost 1 lakh to 1.5 lakhs, where a delay in choosing the right antibiotic can be adversely impactful on the patient, we get the test done. But otherwise, if it's a patient who's improving, not in the ICU, stable patient, we wait for the phenotypic resistance to come before we decide.
Thank you. So in the event, in the interest of time, we'll wind up the session. Thank you again, Dr. Ramasubramanian. Let me invite my co-chair, Dr. Uluwathige, to hand over token of appreciation.